There you go. Awesome. Very good. That's great. Okay, Dorfar, I will, you start recording, okay? Bye-bye.
Okay. Hello, everyone. Do you guys hear me clear, Dr. Tadul? Tell me how you can hear me. Just make sure. If you can type if you want, and type if it is yes. Okay, you can. Thank you. Okay, everyone. Good afternoon. I hope you had a good day in the clinic. I saw many of you in the clinic, so DS4 is winding down. I'll just give you a quick overview of where we are going with this. The first lecture, Dr. Dadul came in and talked about role of CBCT in digital implantology. And I went over digital implantology, which was a cover-up and which was a follow-up of what Dr. Dadul talked about. And now we are going to go over implant-supported removable prosthodontics or implant-supported removable overdenture. That's what our intention of our implant program is, to teach you implant-supported overdenture and single tooth implant, because that's going to be a major part of your private practice. So I divided the lecture into 3 parts. I go over the effectiveness of implant retained prosthesis. Then I would go over steps, how we do it, and then we get to the nuts and bolts, how you secure the attachments. Because I and Dr. Gorham, we observed in the clinic that there's not clear understanding how to pick up these attachments. So we felt we need to enhance this part of our lecture. So the effectiveness of implant retained prosthesis, that would be a point of discussion with your patient. So you can say, if your patient doesn't have a very retentive denture, especially lower, the implant supported, it's going to help it to stay better. Still, you need to have a support, means you get some support from residual ridge, but the retention would be improved. And the other advantage of putting implant, you have less bone resorption. So these are the point of discussion when you talk to your patient who are interested in implant-supported overdenture, or if you want to propose that treatment to them. And I have references for as much as I could, as much as it's related. So you guys become to a habit of having a support of what you're discussing and talking to your patient and your colleagues. Patient responses about fit adaptation and social confidence has improved significantly with implant-supported overdenture treatment compared to complete denture. These are well established. There are several papers that they documented that aspect of implant-supported overdenture. One question coming many times, the patient asks us, is this removable? Is this implant? My denture still moves? Yeah, our response should be yes, there's still movement, because the distal part of our prosthesis is going to rest over the retromolar pad and residual alveolar ridge. And then the question is coming, is fixed implant supported denture better than removable implant over denture? You have to say for removable, we need more adjustments, more wear and tear, more repair than that of for fixed prosthesis. And then fixed prosthesis, sometimes they exhibit limited satisfaction with cleansability. Sometimes patient cannot clean under them very well, and sometimes the saliva or the food get underneath, and sometimes when they talk, they may impede their talk. So the issue of cleansability is an issue with fixed implant restoration. But in general, removable prosthesis, uh, patient, we have to inform our patient they need more adjustment and they need to come for repairs and attachment. I'm going to go over this aspect throughout this lecture 2 3 times because we always deal with this issue when patients come back for adjustment or repair. First and foremost, when we want to plan for implant-supported overdenture, there are several papers out. They are having an average number. Minimum is 12 to 14 millimeter from the crest of the alveolar ridge or soft tissue to the opposing denture, opposing maxillary. We need at least 12 to 14 millimeter. We need this much room for denture, teeth, denture base, attachments, and the placement for the abutment. So when we place implants, when the, the purpose of our lecture is implant-supported overdenture. So the retention mechanism is uh, when you place this implant, in general they are unsplinted. So our intention at UD Mercy Dental, our clinic, is to have implants placed according to the surgical guide. We want to have them as parallel as with each other as much as we can, because then we can place locator abutments and then we can have good retention. But in some situations, sometimes we get if we don't use surgical guide or we don't have them parallel with each other, sometimes implants come in different angulation, as you can see in the bottom picture. When we have a case like this, if we go ahead and place the locator or any type of attachments individually, one of them is going to wear off faster, and then patient have uneven retention, which they don't like. So in these cases, we splint them together with a bar, so we make them all parallel with different type of attachments. So, or same type of attachment, but anytime we add a bar to a treatment, we are adding to the cost and complexity of the treatment. So the purpose of our teaching you the overdenture principles is to place implants according to the surgical guide, according to the teeth setup, have implants as parallel as with each other as much as you can. Then we can place locators. We have an acceptable outcome. But if someone places implants for you or refers something to you without your consultation and each implant go every direction, then the cost of treatment would exponentially go higher, and then patient do not like to have additional cost which was not mentioned to them. So what are the advantages of implants retained overdenture? um, you don't need to have extensive surgery compared to a fixed. You don't need sinus elevation. We have fewer implants as required, and that decrease the cost and decrease the fear of surgery. The other advantage of implant-supported overdenture is we can have support of soft tissue because we can add acrylic, and then we can improve aesthetics, especially facial aesthetics. And these are documented by Johns and Comp and Merckson Stern paper. And then we have we have good suction, we have pretty good adaptation. So the phonetics somehow it is improving, and since the denture is holding in place, patient can articulate words a lot better. And then the most important thing, patient can have access for oral hygiene. They can clean them a lot easier than fixed restoration. So what are the disadvantages of implant retained overdenture? Um, as I mentioned in the previous slides, previous presentation, we have higher incidence of complication and frequent maintenance, more mechanical problems like uh, tooth and base repair. And then we have to replace the attachment as they are worn down. They are bulkier. Sometimes patients say, I don't have room for my tongue, and they compromise tongue space. And again, they are prone to chipping and fracture. So we need to inform patient for future tooth and base repair. So my question to you is list advantage and disadvantage of implant supported overdenture. So we went over the advantages that you can have better aesthetics, you have better facial and lip support, and better phonetics. And then the disadvantage is future chipping, future repair, and future attachments replacement. So these are the comments I would like you to know for your discussion with your patients, and when you come to the clinic, you should be able to uh, articulate those for your patients. Now we went over the indications for implant-supported removable overdenture. Now we are going to go over the clinical steps for implant-supported overdenture. Say we have a patient come in, I'm interested in implant, they don't have any dentures or have a few teeth that they need to come out. The first thing we recommend for phase one, we would like them to have maxillary and mandibular interim CDs. And the codes are as follows on the axiom: D5810, D5811. So get your patient, if you need to do alveoloplasty, perform alveoloplasty. If you need to do some soft tissue surgery, perform that. Then make upper and lower interim complete denture. And after that, you can fabricate a surgical guide, which would be a lab process. We recommend we do a lab process surgical guide. I'm going to show you why. And then CBCT on your treatment plan. CBCT of both jaws is recommended. Even we do a lower, if patient is interested in knowing how much bone they have, you can order both, but you can order only one. But I put the code for both arches. That would be a point of discussion with your clinical faculty if they want to order both, or they want to order only lower. If they suspect any pathology, or if they want to see the maxillary sinus for other reasons, we need to have CBCT of both jaws. Then we have phase two. So we treatment plan our patient for phase one. At the completion of phase one, we order our CBCT with a surgical guide. Then we go for phase two treatment, which would be a new maxillary complete denture and a new mandibular implant supported overdenture. And the codes are 5110, 6111, and two prefabricated abutment, which is 6056 times 2. So these are what we need to put into our treatment plan. So before we do, these are the steps that we need to complete before implant placement. It is like making complete denture. We make preliminary impression, final impression, and then we, in some cases, if you want to just evaluate if your preliminary impression are okay, we can go for that reason. We don't need the final. Then you make record basis, you do VDO, maxillomandibular record, you have a teeth arrangement, you see patient like the aesthetics, the phonetics, then you duplicate that teeth setup in don't know why this jumping back and forth. So you make your maxillomandibular record, and then after you make maxillomandibular record, you duplicate the teeth setup in resin, and then and then you order your CT scan with this clear resin. And you can see the CT scan here. You know the boundary of your denture, you know the bone. We know if the bone are going to be where the implants are going to be placed, if we need to have augmentation or we need to have alveoloplasty. We can figure all of it out based on that CBCT with the surgical guide, radiographic guide in place. And then when we want in some situation, we use radiographic markers, as I'm showing you here, to show you the boundary of the denture. But in general, a surgical guide that would be adequate with some gutta percha point or with some markers. I'm showing you two techniques to make a radiographic guide. You can duplicate a denture. There is a flask here. You fill one side with alginate. You put the teeth set up in it, and then you let the alginate set up. Then you put separating medium between them, and then you fill with alginate here, and then you close it together, and there is a knob here. You close that knob. As you can see, I saw it in the clinic. I took a picture of it. The surgical guide, would it work? Yes, but you don't have any visibility at the time of surgery, because in general they are porous and don't appear clear. So therefore they impede visibility during surgery. So when we want to make a radiographic guide, we recommend we make a lab processed duplication. The Axiom code is D6190. The advantage of lab processed duplication, it's clear, it improves visibility, it is strong, it doesn't break during the surgery. So there are a lot of advantages by doing that. But I was going to draw your attention. There are duplicate flasks in the clinic that it makes a guide, but it is not a very useful guide. So you make a surgical guide. As you can see here, it's clear resin. So when you go to oral surgery or perio, if some of us are going to do, I place my own implant. If you do it in the clinic, you use that guide as it was marked during the CBCT, as Dr. Dadul mentioned it in his lecture. And then later on, we are going to go over the software, how you determine where the implant is going to be. But that's the key for placement of the implant. So the implants are placed according to the surgical protocol. After the surgery, we reline the existing denture with a soft liner, and then we allow 3 months of healing for the mandibular arch. Within that 3-4 months, you may have to replace that reline several times, because as patient heal up, the swelling would go down, the denture becomes loose, you have to reline it. And it's one of the codes that you have to write it. Sometimes we write it off, but we are going to incorporate the tissue conditioning into our fees. After 3 months, the healing abutments are placed. As you can see here on the left hand side, you can see the head of the implant is at the crest of the soft tissue. A short healing abutments placed. Again, because there is a tissue punch, they'll have to make incision to place the healing abutment. We need a couple of weeks of soft tissue healing. Then you start fabricating the overdenture. So again, you have a custom tray from phase 1, or you can make a preliminary impression, make a custom tray, the same step as making conventional dentures. We make impressions, final impression with PVS. We determine our VDO and in maxillomandibular record. We do anterior trying, posterior trying, because based on the first phase, sometimes patients want to have wider teeth, sometimes they want to have whiter teeth, sometimes they have smaller teeth. So you can address all their issues in phase 2. And then You do your teeth trying. When your patient sign the consent, you process your dentures. I'm sure all of you know by now how to make a denture, and then you request the lab to make concavities in the intaglio part of the denture, overdenture, to make room for your attachments. As you can see in this case, we requested metal reinforcement because the inter-arch space was minimum. If we go with the bare minimum, patient may break it. So we order metal reinforcement for the overdenture. So the overdenture, its process is come back. You deliver you deliver a complete denture. You make sure it's not hitting over the healing abutments or the and then you adjust the border, you adjust occlusion, and sometimes we don't pick up the attachment the same day. So now I go over the nuts and bolts, how we select our locator abutments, and then how we can attach those. As I'm showing you, let me get the hand here. I'm showing you hand here. This is the intaglio surface of the overdenture. I'm going to show you how we select what type of abutment, how tall the abutment should be, how we attach these made attachments to the overdenture. So on the top of our implant in the patient's mouth, it's going to be a locator abutment that you remove the healing abutment, you place it. And then inside the denture, you have a denture cap that would be attached to the denture base with the help of acrylic resin. And I go through step by step how we do it. We need several instruments and material. The ratchets are in the Zimmer prosthodontic kit. And within that prosthodontic kit, you have a locator tool, which comes apart into three parts. The gold part is where you tighten the locator abutment. The middle part is the male sealing tool, and the hook shape. And the new ones, they are straight shape. I show you both. These are the called male removal tool. So what it does is like a hook, it gets inside the denture. If you want to replace existing attachment, it would help you to facilitate that. And then we need to have a denture repair material. These are the tools we need to check from materials management and from dispensary and materials, and from clinic we need to order this locator abutment. I go over it, how you select what type of locator abutments you have to order. And I'll show you here the locator driver. That would be Zimmer. It would go inside the gold insertion tool, and then you can tighten it. So this is a locator abutment in close-up. The top, if you look at the bottom, that's the screw that would be engaging the inside of the implant. And then the gold part, the lower part of the gold, and up to this trough here, we call it cuff heights. It depends, the cuff height is determined by the thickness of soft tissue. Some patients, they have thick soft tissue. Some patients have 2 millimeter. Some people, they have thin soft tissue, 1 millimeter. Some people have a lot of soft tissue. We can go up to even 4 millimeter of cuff heights. Because what would happen if patient have a lot of soft tissue and then we use a shorter one, then the denture, overdenture cannot engage the head. The head part, this part of the locator is the retentive element of it. But if it's under the gum, the denture cannot reach and grab a hold of it. So now we go to the next slide that I show you how we determine that. This is my own patient. This is the top of the implant. This is the top of the gum. Healing abutment is removed. I already placed my locator. As you can see, that was the smallest locator. At that time, they didn't have more than less than 1 millimeter height. I had to go with 1 millimeter. Now we even have 0 millimeter. So nowadays, we can even at the zero height, zero soft tissue height. So we measure the distance between the top of the implant, not the inside of the implant, the border of the implant when it comes in contact with the soft tissue to where the edge of soft tissue is. We measure it. It's 2 millimeter, we record it. 3 millimeter, we record it. Then we order the locator abutment according to the height, so according to the cuff height. So they order your locator, patient goes home, you put the healing abutment back in there, send patient home. Your patient comes back, then with the seating tool, which has a triangle at the end, and this is a torque wrench. You put it in the patient, remove the healing abutment, you torque it to 30 Newton centimeter, and then you are ready for the next step. So you deliver the prefabricated locator abutment. When you order locator abutment, the male attachment set order would come with it too, which you can see there are different colors here. These are the components that would be incorporated, that would be attached to inside of your overdenture. You open it up, you lay it on the dark background, because if you put it on your white tabletop, you may lose some of them because there are some of them white, some of them are clear. So I go from left to right. We have two implants. We have two caps. We call it denture caps that would be attached to the inside of the denture. We have a blockout spacer. I'll show you what they are. Then we have two clear, two pink, and two blue. And then inside our denture cap, there is a black processing that we have to replace after we attach them. I show you step by step how we do. So when it comes to this step, sometimes many times I do one and then you do the other one. But if you familiarize yourself with the steps, the appointment goes a lot smoother. So what is the different color locator attachments signify? They signify durability, retention, or type of material. All of the locator attachments, let me go back, they are made of the same material. All these colorful, clear, pink and blue are made of the same material. So all the materials are the same. Durability, they have the same durability. What it signifies, the color, is the amount of retention. The blue is the least retentive one, then the pink is the more retentive one, and the clear is the most retentive one. That's the one we use in our clinic. And the black male processing one is the one that doesn't have a lot of retention. You get good suction, for lack of better, or good fit, but you don't get a lot of retention. Okay, so that was a lot of technical. I'm going to show you this slide. This is in Miami. That was our annual meeting before COVID. We went there. It was great weather, and it is yeah, it is nice. Yes, actually, Dadul agrees. Yes, so I highly recommend when you go there, go to Fontainebleau. You can walk to the beach, and if you don't like crowds, you can go after sunset. It's beautiful. So between our meetings, we could go there and come back. So I highly recommend it if you go there for a conference. That was a very good meeting last November. All right, now let's switch back to where we left off. So I'll show you the attachment, I'll show you the locators. Now I'm going to show you how we use them. So locator tool is separated into three parts, as I mentioned before. The optional driver, that's the one you use to place the locator. We have a designated driver into Zimmer. This is an optional one too. We have a seating tool that you can insert those male attachment inside the denture. There's a removal tool that you can remove those colorful male attachments. So I show you how it goes. So this is the removal tool. This is the one we have in the clinic. We have both. I'm showing you both of them. You can see there is a lip here. There is a sharp edge that when you insert it inside the locator, inside the denture, you can pluck it out and remove the black processing unit. So that's the purpose. That's a close-up view of it. So this is a locator retentive rings. As I mentioned to you, the cap would be, as you can see, it has two grooves. It would be incorporated inside your denture with the denture repair material. Inside that metal cap, you have these attachments. As I was telling you, blue, uh, pink, and clear. Blue has 1.5 pound, pink has 3 pounds retention force, and then clear has 5 pound retention force. If you have a 20-degree angulation between the two implants, they would work. So how does it work? I showed you how the top of the locator look like. This is a negative part of it. There is a inner undercut that would engage inside the locator, and there is an outer undercut that engages outside the locator abutments, as you can see here. Okay, excuse me. As you can see in the next picture. So as I was showing you, it would engage here. There is an inner retentive element and there is an outer retentive element. So how do we go about attaching that to inside of our denture? We place our locator over the implants. So now we want to put our denture there, and then we call it a pickup. When we tell you pickup, you need to have a blockout spacer. You slide that spacer over the locator. So what it does, the blockout spacer prevents because we have excess acrylic that would run over the bottom of the attachment. If we don't have this blockout material, it would grab a hold of underneath the outside of the locator and lock it into place. So we have to have that blockout spacer at this point before we pick up our attachment inside the overdenture. So you place your blockout. Again, what's the purpose of blockout spacer? It doesn't improve retention. It doesn't secure the cap to a denture. It prevents the lockdown of excess acrylic. So know that this is very important. I put it in a question format, so it would you have a good memory. It would stay with you. So this is the locator denture cap. That what would go inside the denture. So we place our abutment, our locator abutment. We place our blockout material, blockout ring here around it. Now the denture cap, we put it over the locator. So when we put it over locator, you hear an audible click. You hear an audible click. So as I was telling you before, you ask the lab to create room for your locator, or if the lab hasn't done it yet, we can create it with an acrylic burr. So the metal cap, the denture cap, would be attached to the inside of our overdenture with acrylic resin. We place the spacer around the locator below the cap, so the material doesn't lock our dentures in. So we identify locator in the denture, and then we create or we modify the concave recess inside the denture with an acrylic burr. We have to verify, this is really important, we have to verify the passive fit of the denture on the tissue with no contact to the denture caps. There should be no contact. And then I understand some of the steps you haven't done it. We are mindful of this. But if you review this one before you come to the clinic, the appointment goes a lot smoother. This is autopolymerizing acrylic resin or denture repair resin. You dry up the attachments, and then your denture is fitting right, the occlusion is right, the border is acceptable. You apply small amount of acrylic on the top of denture cap in the denture where the recess is, on the denture cap recess. And then you inject a little bit around the head of it in the mouth. So that's where you and your partner, you have to synchronize this step of the appointment. You don't want You have to go. You have to go very quickly. We don't need to have a lot of saliva. It has to be dry. And if we stay with these steps, the outcome is going to be great. But if we don't pay attention to detail, sometimes the denture is not seated completely, or we have too much acrylic, or we don't have good mount. You ask your patient, you seat the denture, and you instruct your patient to maintain a passive light centric occlusion. So before I do this, we try 2-3 times with our patient. So your patient bites down, gently holds it in place. So what it does, the acrylic fully cures within 5 to 10 minutes. Wait 10 minutes. And then after 10 minutes, you remove the denture as such, as you can see here. You may have to you have to break the suction. There's going to be a good fit here. That's the best fit you ever had, because after that, you have to remove some acrylic. And when you remove acrylic, you lose some of the ideal fit. So you remove the denture, you start adjusting it with acrylic burr. There are going to be some flashes I'm showing you here. You adjust with acrylic burr. See, this is the black processing unit. You grab your removal tool. We have to remove it. Sometimes we ask you to leave it in there for 24 hours or 1 week. Then we replace it. But in general, if everything's all right, we remove it. We pluck that black processing, we call it processing insert or black processing insert, and then we place it with the blue one. Blue is the first attachment that you do. As you can see, when you remove it, there is some retentive element inside the denture cap that allows you to place the next one in there. Then you grab the retention ring. In this case, we tried the blue one. Patient want to have more retention. We moved one step up higher. We went to the pink. It's orange, if you ask me. This is orange. This is the seating tool, and then you put it in there. You push it in there, and then you hear an audible click. If you don't hear an audible click, have one of us look at it in the clinic. You may have to replace that insert, that retention ring. And then after that, you do the same thing for the other abutment. And then here we go, you're done. Before you dismiss your patient, you give the care instruction for the overdenture to your patient. It's the same as regular denture. You ask them, you have to clean it. They have to clean the abutments. You remind them the attachment need to be replaced because of normal wear and tear. And we bring them at least twice a year, especially after we deliver the lower implant supported overdenture. So there is a lot of steps. I understand you may not get all of it first round. Please review it. Come back to me or Dr. Guron or one of the pros faculty in the clinic. We would be glad to go over it with you. It's a pretty complicated concept. Uh, as I was mentioning to you, we are here in the clinic to help you. We do one, you do the other one, but we would like you to be at least knowledgeable about what we are doing. So I see there is a question in the chat room. Nice picture. Oh, thank you. Thank you. Do you guys have any question? You can put it in the chat room. But this is all I have. I would like to appreciate your kind attention here. This is the future. You need to be knowledgeable about this part. And if you have any questions, please put it on the chat room. And I put some of the highlights throughout the lectures. And next week, Dr. Gurun, oh, thank you, everyone. You are very kind. Thanks, Farzin. Thanks, Carly. Thank you, all of you. Thanks, Jennifer. Thanks, whoever was present. But I'm reading off of the chat room. Next week, Dr. Gurun is going to go over the single tooth implant. Please, I send the announcement so you guys can come and attend. As I mentioned, I recorded the lecture today. I'm going to stop recording. You can even raise your hand if you have any questions. If you don't have any, I wish you a good evening, and I see some of you tomorrow. I see the rest of you on Monday.